Thank you. I'll be talking about management of traumatic cataracts with manual small incision cataract surgery. I'll be showing few videos here. This is the first video of a blunt trauma with ruptured anterior lens capsule, which on staining is looking like an Argentinian flag sign. So this tear is converted into a partial capsular excess on both the sides, and as the status of the posterior capsule was not known, I avoided in hydro procedures, and just with the help of viscoelastics, I prolapsed the soft nucleus out of the bag and out of the eye as well. So as I've used viscoelastics throughout, chamber was well formed, and at the end, when the PC was found to be intact, a lens is placed in the capsular bag, which was found to be well centered. This is another case of inferior subluxation of around 4 clock hours with nuclear sclerosis grade of around 3 to 4. So here I have fashioned a superior sclerocorneal tunnel. The architecture of the tunnel should be very good, otherwise the chamber will collapse now and then during the surgery and can compromise the surgery in the form of vitreous prolapse in the anterior chamber. So fashioning or aiming for a capsular excess of at least 6, and then after doing visco dissection, supported the bag with 2 iris hooks and a CTR. One can always use a capsular hook. And then after doing hydro dissection, nucleus prolapsed and the lens is placed in the capsular bag. There is one more case of nasal subluxation of around 6 clock hour, and one can see that the wrinkling on the anterior lens capsule suggesting gross zonular weakness. So after fashioning a temporal sclerocorneal tunnel, I have initiated my capsular excess with cystitome. The grade of the cataract is almost 4+, and now switched over to Utrata forceps for better control. As the size of the capsular excess was not adequate as compared to the grade of the nucleus, I did a partial double excess here, and then supported the bag with 3 hooks and CTR. And after that, I've done a dissection and delineation. Delineation will reduce the size of the endonucleus, which can then be prolapsed bimanually. So in bimanual prolapse, the Sinski goes towards the equator, pushes the one pole out, below which the second instrument is or spatula is placed, which will act like a fulcrum, and over which the nucleus will be dialed out. And then after removal of the nucleus, after removing the cortex, as the bag was very weak, I decided to implant a CTS and sutured it to the sclera, and a single piece lens is placed in the capsular bag. There is another case of anterior subluxation of lens where almost 2/3 of the lens was in the anterior chamber. So I decided to go for intracapsular cataract extraction combined with acefoil. I usually prefer the Gabor's sutureless technique. So for that, I begin with fashioning the chariot tunnel first in a form chamber on both the sides. So after I formed the chariot tunnel, made the incision, superior tunnel, and then prolapsed the nucleus. I mean, not only nucleus, the whole cataract in the anterior chamber. Visco is injected to push the vitreous down, and the whole cataract is removed in toto without any vitreous disturbance. So what I do little different from Gabor's technique is that I usually pass a suture material through the dialing hole of a rigid PMA IOL, which will act like a sling and prevent any IOL slippage or IOL drop during the manipulation. So after sclerotomy, you can see that I passed a suture material. This is called IOL sling technique, got published in IGO in 2020, and this video will make it more clear. Dialing hole, through the dialing hole, suture material either 90, 10, nylon is passed. The ends will be outside the tunnel throughout the manipulation, which will prevent any IOL drop or slippage. You can see that while taking out the leading haptic or the trailing haptic, the suture material is outside, and once the IOL is found to be centered, the sling will be cut and removed. So this is my last case where you can see that there is a nasal subluxation with wrinkling of the capsule. Here I was not fortunate enough to have a adequate continuous capsular axis, so CTR I could not implant, and as the size of the, as the support of the bag was not adequate, I decided to go for iris suturing of at least one haptic of the IOL, for which I have passed a Prolene suture, 90 Prolene suture through and through the iris, and the loop is taken out from below the iris, out of the eye through the tunnel, and will be looped on the leading haptic of the IOL, and after looping it, the IOL will be placed in the sulcus, leading haptic first, followed by the trailing one. And once IOL is found to be stable, both the suture ends will be taken out through the same parasynthesis and will be sutured in the manner of 3-1-1. So then IOL is well centered. So to conclude, each case is different, and although traumatic cataracts are extremely difficult to manage, but with excellent surgical skill and timely management, one can prevent complications and provide better visual outcome. Thank you. Thank you for listening.
Thank you, Dr. Manas.